Good afternoon, ladies and gentlemen. I'm Dr. Bryan Lin from Taiwan. My pleasure to share this topic, video quality and patient satisfaction with over 3,000 LENTIS segmental refractive IOL implantation. First of all, I will thank Teleon's invitation. Presbyopia, as we know, is physiological insufficiency or accommodation associated with the aging of the eye that results in progressively worsening ability to focus on near objects. This slide highlights the various methods we have explored over time to correct presbyopia, including spectacle lenses, contact lenses, corneal inlays, laser ablation, scleral expansion, pharmaceuticals, and a variety of presbyopia-correcting IOLs. Additionally, methods such as intracore, supracore, presbyon, and ICL has also been introduced for presbyopia correction. Today, I will focus on presbyopia-correcting IOL in affected eyes. During cataract surgery, we employ techniques such as monovision, simultaneous images, pinhole depth of focus extension, accommodative, and multifocal theory to treat presbyopia. I want to highlight that these IOL are specifically designed to treat presbyopia undergoing cataract surgery. Multifocal IOL can be classified by their range of vision into high-ad, intermediate ad, and low-ad IOLs. A new type of EDOF IOL is designed to create a single elongated focus point rather than multifoci to enhance stable focus. This approach aims to reduce photic phenomena such as glares and halos, which are commonly reported with multifocal IOLs. Lens covered is the first EDOF IOL on the market. This table demonstrates the advantages and disadvantages of high-ad versus low-ad presbyopic IOLs. In general, low-ad presbyopic IOLs offer better quality of vision for patients with reduced light loss, halos, and glare. This slide presents my first 1,000 cases of presbyopia correcting IOLs. It took me almost 7 years to get there, from 2006 to 2013. During this period, I used high-ad bifocal lenses, such as Restore and Techniques, as well as accommodative IOLs. LENTIS IOLs were not yet available in Taiwan during this period. My second 1,000 cases of presbyopia correcting IOLs were completed in just 2.5 years from 2013 to 2015. During this period, I continued using high-ad bifocal and accommodative IOLs and began incorporating intermediate-ad multifocal IOLs, such as Restore 2.5-ad and LENTIS NF15. From 2015 to 2018, I completed my third 1,000 presbyopia correcting IOL implantations. During this period, I began using trifocal IOLs. The use of intermediate-ad IOLs such as LENTIS NF15 steadily increased to 1/3 of my cases. LENTIS IOL were used in 906 of these 1,000 cases. I reached my 4,000 presbyopic IOL implantation in 2021. The use of intermediate-ad IOL grew rapidly to 81% of my cases, surpassing the use of high-ad trifocal IOLs. LENTIS IOL were used in around 850 of these 1,000 cases. During my fifth 1,000 presbyopia IOL implantation, the use of intermediate IOL increased significantly, reaching 90% of my cases. Additionally, I began incorporating low-ad multifocal IOL during this period. However, I still use the LENTIS IOL in more than 700 of these 1,000 cases. These are the presbyopia correcting IOL I currently use in my practice. The use of intermediate ad IOL remain high, while low-ad IOL are steadily used. LENTIS IOL is still the most frequently used in my practice. This figure shows the day 1 post-op UDBA result for eyes I implanted with presbyopia correcting IOLs. Notably, 45% of eyes achieved a monocular UDBA of 20/20 or better. I also achieved UMBA of day 3 or better in nearly 90% of eyes. On day 1 post-op, there was no significant difference in UDBA between the high-ad group and the intermediate to low-ad group among these eyes. This figure shows the post-op UNVA result, where 95% of eyes in the high-ad group achieved day 3 or better for near vision, and 55% achieved day 1 or better. This figure shows the distribution of my various presbyopia correcting IOLs. High-ad IOL are the most frequently used presbyopia correcting IOLs in my practice. However, after analyzing the data, we can see that the usage of intermediate ad multifocal IOLs was very low during the first 2,000 cases. Recently, I have been using intermediate and low-ad multifocal IOL in more than 98% of surgical eyes because they offer certain advantages in terms of patient outcomes. This figure shows a higher percentage of patient satisfaction as the proportion of intermediate and low-ad IOLs used increases. To achieve a higher success rate with all types of multifocal IOLs, precise alignment is crucial and presents a significant challenge. This slide explains angle alpha and angle kappa. Angle alpha is the difference between the linear center and visual axis, while angle kappa is the difference between the pupil center and visual axis. In this image, we can see visual center, photopic pupil center, mesopic pupil center, capsule center, that is 5-5 center. Almost all cornea topographers on the market can detect these important data. During surgery, we use Purkinje image 1 under the microscope as a reference for alignment. This video demonstrates Purkinje image on the LENTIS Mplus under the microscope. Purkinje images on the LENTIS comfort are more difficult to observe. However, they can be seen by tilting the body of the LENTIS comfort to make sure the alignment. If patient's angle alpha is too large, the center of the visual axis will fall on diffractive ring. Is this still necessary or worthwhile to implant diffractive or refractive multifocal IOLs? No, I don't. However, unlike the diffractive or refractive multifocal IOLs, the LENTIS IOL can be rotated to prevent the visual axis from aligning with the near segment. Next, I will show the surgical management of challenging cases by using the LENTIS IOL. The first case involves using the LENTIS comfort toric IOL in a patient with high myopia and high astigmatism. Considering high myopic retinopathy, we recommend this patient to use LENTIS comfort. We conducted a thorough pre-op examination on right eye and left eye. We input the examination result into the calculation formula and obtained 4.72 diopter cylinder power and 3 diopter SE on the right eye. And we scheduled 5.06 diopter cylinder power and 3.5 diopter SE for left eye. On the first post-op day, the ratio cylinder was minimal, less than 0.25 diopter, and the BCVA reached 20/20. The second case is using LENTIS comfort in a traumatic eye. This patient achieved nearly 20/20 vision on the first day post-op, and reached 20/20 on the first month post-op. The third case, we use LENTIS comfort in a mild ARND case. Post-op, this patient was very happy and very satisfied with the visual quality, including night drive. Case 4 involves a post-RK patient with 16 cuts more than 20 years ago. Also considering high myopic retinopathy, we recommend this patient to use LENTIS comfort. IOL calculation in post-refractive surgery patients can be particularly challenging due to the changes in cornea curve. Using multiple measuring instruments, such as an optical refractor and a topographer, along with various calculation formulas, can help improve accuracy. Post-op visual acuity and visual quality was pretty good, and this patient is very satisfied with LENTIS comfort. Next, in a case like this, where the patient has a history of high myopia and underwent LASIK 20 years ago, along with current high myopia retinopathy, careful consideration is needed for IOL selection and calculation. We choose LENTIS comfort to minimize the risk exacerbating retinal issues. Post-op visual acuity and quality were quite good, and the patient is very satisfied with its comfort. The UDVA was 0.9 in both eyes. The last case involves a patient with very high astigmatism. From optical refractor and topographer, we can see the cornea astigmatism approaching 8 diopters. After a careful and thorough pre-op examination, I have scheduled a toric LENTIS with an 8.44 diopter cylinder power of this case. After surgery, the UDVA and UMVA was very good, and almost no astigmatism was observed. Next, I will compare the post-op or visual outcomes between LENTIS comfort, Mplus MF30, and Mplus MF20. 3,260 eyes were involved in this study. The purpose is to compare the post-op visual outcomes among low at LENTIS comfort MF15, intermediate at MF20, and high at MF30. They were evaluated for pre-op UDVA, post-op UDVA, and post-op UMVA. The day 1 post-op monocular UDVA for all LENTIS IOLs was better than 1.2 in 8%, better than 20/20 in 48%, and better than 0.5 in 97% of surgical eyes. The day 1 post-op monocular UMVA for all LENTIS IOLs was better than J1 in 11%, better than J3 in 77%, and better than J5 in 86% of surgical eyes. On post-op day 1, there was no significant difference in UDVA among the 3 groups. In this figure shows that the high at MF30 IOL provided the best post-op UMVA. This figure shows at the number of cases increased, the proportion of high-end IOL users significantly decreased, while the use of intermediate to low-end IOL gradually increased. Here's a summary. Teleon-Lentis Comfort Mplus IOL contribute laser halo and glare, laser compression in dim light reading, the contrast optic with only 5 to 7% loss of light, better intermediate vision, forgiving lens with minimal refractive error, user-friendly, suitable for post-LASIK, post-RK patients and some difficult cases, a wide range of available power, achieve high patient satisfaction, and customized LENTIS Mplus codec is available. My conclusion about LENTIS Mplus and Comfort IOL. LENTIS implantation is not as difficult as initial thought. The results are much better than traditional presbyopic IOLs and suitable for most complicated cases. And thank you for your attention.